You're live.
Okay, so Senate Health and Welfare, we're back looking at two bills, H 573 and H 293. We're going to spend just a limited amount of time on each one so that we can finish with time to get to the floor. So we're going to try and finish by 20 after. Okay, so that gives us 25 minutes.
Okay. Let me share my screen. So it sounds like we'll look at 573 first. This is the bill about the first certification for emergency exams and who can do the first certification. Right now it's physicians and APRNs. And then this adds physician assistants. That's the substantive change that's happening. Would you like a refresher of?
Yes, please.
Okay, so section 1 is being struck through. It was recognized when this bill was in House Healthcare that this language, I don't want to say antiquated, but it was out of sync with what the current practice is with regard to who is providing this first certification. For example, I think it says that a psychiatrist does it, but if a psychiatrist can't do it, they could designate another physician. The practice is that a physician does the first cert and a psychiatrist does the second cert. So this language, it was asked that this be removed. So that's what's happening in section 1. Section 2. Instead of an interested party submitting an application for an emergency exam, it's being changed to a qualified mental health professional. So upon written application of this qualified mental health professional made under the pains and penalties of perjury and accompanied by a certificate, instead of by a licensed physician, it would now read a healthcare professional. When we get to the very end, that's where our definition of healthcare professional is. So this is a person who's not the applicant. The person is held for admission to a hospital for an emergency exam if the person is a person in need of treatment, meaning they meet that statutory definition of meeting the level of care required for hospitalization. The applicant and the application certificate set forth the facts and circumstances that constitute the need for an emergency exam, that the person is a person in need of treatment. That's existing law. Also existing law is subsection B, about transporting the person for the emergency exam. In subsection C, and to refresh my memory, this section is being rewritten, not necessarily to just effectuate that PA being able to provide the emergency exam, but also because when House Healthcare was reading through this section, they found the wording confusing. So some of this wording has been changed to try to make the same statement in a more clear manner, hopefully. So it reads, admission of an individual to a designated hospital for care and treatment under this section shall be overseen by a head of a hospital who may designate a person in writing to discharge the authority granted in this subsection. So the head of the hospital.
Who's the head of the hospital?
That was a big conversation upstairs. Boss ended up answering that question, who I know you have in the room, so I would love to
Hear from, yeah.
Okay. And then the second sentence of that subsection C is being changed to conform with other changes in the bill. So a designated person must be an official hospital administrator, supervisory personnel, or licensed physician on duty on the hospital premises other than the certifying healthcare professional. So other than the person doing that first cert under subsection A. New language added upstairs in subsection D, that prior to issuing a certificate pursuant to this section, so a healthcare professional shall successfully complete a training developed and administered by the department. So the person who is doing that first certification, whether they're a physician, APRN, PA, they are completing a DMH training before they can issue those decisions about the first certification to hold somebody involuntarily in a hospital. Subsection E is our definition. We already looked at this. Physician, APRN, or a PA. And it takes effect on July 1, 2026.
So there's no requirement for the PA to have, mental health training.
No, they have to do the same DMH training that others would have to do.
Okay. And head of hospital, we're going to hear from Boz about that. I know there's an interest in this bill for, from Boz. I know Medical Society is not here. But I also know the Department of Mental Health is also interested in this, so we're gonna hear from both right now. To do that would be helpful. So Boz, I think Devin, you're here.
Morning, Devin Green from BUS, Vermont Association of Hospitals and Health Systems.
Good, and two things. One, we've got your information here in writing. And so we're just trying to figure out what the problem we're solving. And I see it starts out.
The problem we're trying to solve is right now, there are emergency departments that are staffed solely by physician assistants at our most rural hospitals. So when someone who comes in with a heart attack, they're treated, stabilized, maybe transferred by the physician assistant. When someone comes in with a mental health crisis, for that first level of involuntary treatment, first, getting them into inpatient, those emergency departments have to wait for a physician to come in and sign off on getting treatment for that patient, which we feel actually creates inequality, like non-parity. We often look for parity in the mental health space, and it forces people to wait in an emergency department, which is quite a stressful situation for someone in mental health crisis. You all have recognized the value of physician assistants most recently in S-163, where you gave them discharging and admitting privileges. So here, they have admitting privileges in a hospital already. They are doing the work for every other patient that comes in through the emergency department. We don't think that there should be, if they go through DMH's process and get certified that way, we think that they are on the level with APRNs and physicians when it comes to this service. And so we would ask that they be treated accordingly instead of forcing patients to wait.
So in 163, we gave that authority, but we also understood that hospitals have a right to put their own guidance documents in so that a PA does not do certain things. So does that hold within this legislation?
If the hospital determined that they only wanted certain individuals doing these emergency exams, then they could make that decision.
Okay, and who's the head of the hospital?
Great question. In this case, it's the administrator that's on call. So typically there's an administrator on call for emergencies and other.
Is that a clinical administrator? Or is it the chief financial officer? I'm worried about this one.
I did have a good answer in House Healthcare. I can go back and look at what the answer was. I didn't write it down. But let me check on that. I believe there is a clinical component, but I'll double check.
Okay, so we want to.
But that is current law. We're not trying to.
We want to make sure that it is a clinical oversight for this one, because you could have a CFO in there and say, oh, yeah, no, so-and-so did it last week and let her do it again this week.
Well, I just want to make clear that this is just another level of oversight, recognizing that we are, there is a liberty issue here. And so with this process, you have the emergency exam, the first certification, which that's where we would want the physician, the APRN, or the PA to be able to do that. They're able to rule out that this is a medical issue and also that this person needs inpatient treatment. And then the second certification is done by a psychiatrist. And that's done within 24 hours. And then this is another level. But you do have the clinical components in there.
Okay, so go through the process for us one more.
The
The patient comes in.
Correct me if I get it wrong.
Okay,
Patient comes in, the first certification is done by the physician, APRN, and then here we would want the PA to be able to do it too.
so the first certification is it a heart attack?
Yeah, the
Yeah,
purpose
yeah.
is to say, oh, is this,
Discriminate medical.
right, or is this like a urinary tract infection? Because sometimes that affects the brain. Is there a physical cause to this, or is this
Yeah, right.
something that needs inpatient psychiatric care? And then the psychiatrist does an evaluation and confirms or denies and says this person needs inpatient treatment. And then there's this other layer that I actually, quite frankly, until this bill came along, I haven't heard too much about on it. But it is this other layer of having the receiving hospitals say, yes, we can receive that individual. So it's not the head of the hospital where the person is, it's the head of the hospital that's receiving the patient.
Oh. Got it.
Yeah, okay, makes sense.
And in order to have, and this is coming back to me, in order to have a discharge and an inpatient admission to that receiving hospital, that obviously goes through a clinical process. And then I think there's this extra layer of the head of hospital process.
Katie, is that trust but verify, right? You got it. Okay, thank you for that. Senator Benson, no question.
So maybe that answered my question, because I'm trying to figure out process here, because the first item says upon written application by a qualified healthcare professional. So that would say person can't just walk off the street into the emergency room because they don't have this referral. So I don't know how that works.
Do sorry, I shouldn't have jumped in.
No, no.
Okay. So this is just for involuntary treatment. So if somebody is in the community and they voluntarily think that they need psychiatric help, there's nothing to prevent them from seeking involuntary psychiatric help. This process is for the individual who doesn't think they need psychiatric help for but qualified mental health professional or people around the person do think they need hospitalization. This is to hold them and confirm that they do meet the statutory standard of needing care to continue to hold them at the hospital.
It's confusing language.
We'll go back through it again, don't worry, but just to start, so
Yeah,
from Bob's perspective, this is helpful.
this is helpful from our perspective. And I believe DMH submitted testimony about physician assistants qualifications, and I'm happy to provide further testimony about their training and everything else. I don't see a whole lot of difference in the hospital between APRNs and physician assistants in terms of their training and expertise. I think the main difference that we see legally is that APRNs have the ability to, after a number of hours of training, to strike out on their own. They can sort of hang out the shingle and practice unsupervised in their own practice. PAs don't have that ability to do that outside of a hospital setting, but in the hospital setting, very similar sort of qualifications.
Okay. Helpful. Other questions? So we're going to come back and look at the process again and understand voluntary versus involuntary. We need to do that, and we'll get that. Other question. All right, we're good. All right, yeah, we're running up against time, but Claire, you wanted to come up and test. I know that this is difficult for you. I understand your position because the commissioner was not available.
I've never sat here before, so I to follow up on any of your questions that I can't answer. I would also recommend that hearing testimony from the Mental Health Law Project on this. They testified along with DNH upstairs. And I know there's limited time, so if you don't have time for that, I would suggest reviewing that testimony. We did submit, I'm Claire Neal, I'm the Senior Policy Advisor for the Department of Mental Health. We did submit written testimony outlining our position on this. As I said, I might not be able to speak to the details, but I can sort of speak to the broad philosophical implications of the bill. We certainly don't want people to be waiting unduly for care, particularly any kind of emergency healthcare. However, this is not just a medical process. This is also a legal process. The Department of Mental Health carries the burden in court when we pursue involuntary hospitalization. And we want to make sure that due process remains really strong for this set of individuals. They're often very medically complex individuals, people who are very vulnerable. And due process by design does create friction and delay within any sort of process that takes away a person's liberty. It's designed to do that. Removing due process protections will always make these processes faster and easier. And we want to maintain a balance between timely access to care and retaining those protections over people's rights. We also experience healthcare shortages. We run a hospital. We're very understanding of the difficulty of that. But we maintain that philosophically and in terms of our legal responsibilities, we do not want to lower due process just based on shortages. As we said in our written testimony, wait times overall for involuntary mental health treatment have lowered over the past few years. There was definitely a spike during COVID, but they are now lower than they were prior to COVID. And then finally, I heard earlier that mental health professional is not actually laid out in statute. So perhaps our number 4 might need a little bit of work in our written testimony. But we are a little bit concerned about requiring only a qualified mental health professional to begin the process of application. I believe Devin can correct me if I'm wrong, but by contract, a qualified mental health professional is required to do this process for admission to a designated hospital. However, we have some concerns that this would preclude if you are at just a regular visit with your doctor or a regular visit with a mental health professional outside of the designated agency system, that they would then not be able to initiate that process without contacting a designated agency and getting a QMHP involved. QMHP is a specific designation that is overseen by the Department of Mental Health. I think broadly, APRNs were given broad authority under 26 VSA 1616 to sign anything that an MD could sign. DNH recognizes that authority in this arena. I think we were opposed to that expansion when it happened, but we do recognize their authority, and we do provide specialized training to make sure that they're able to perform for certifications. And if the committee chose instead to sort of provide that broad scope of authority for PAs, we would of course recognize that, and we would work to adapt our training to make sure that it's.
So it's the issue of having sort of a PA here and a PA there and the training. So there's uncertainty from the department's perspective about the training. Overall, understood. Okay, this is all helpful. And thank you for bringing in the written comments and the data on changes. It's really good. Okay, questions for Claire? But this never is as simple as it appears. So this is more complicated than that. And I know that the Mental Health Law Project might want to discuss that. Jackson. Yes.
I was going to say, where's Jessica?
I know. He should be sitting. He's probably sitting here with us.
After this, we come and do an voluntary education.
Yeah. Okay, so thank you. We're gonna move right along to 293. We'll have like 7 minutes, 10 minutes. This one, we're gonna hold on to. We'll see what we can do with it. I understand it's important. Nothing more important than making sure that people get the mental health treatment that they need effectively. Totally agree. Okay. Thanks, Claire. Good job. So we have 293 and Lauren Lehman had asked to talk about this one, but maybe, Katie, you could give us the,
Quick refresher.
yeah.
Sure. Okay, so this is a Department of Health bill. The first section is reporting requirements from the Health Equity Committee. So they currently have an annual report, and there's a request for it to be a report every 3 years. I'm sure you'll hear from Lauren, but the health department has submitted several pieces of information, several documents asking for changes. So this is one of the changes, the date here. And then the following 2 sections have to do with the disclosure for registries. So we have the cancer registry, and then the ALS registry in section 3. And it's the same change, just striking out approval of the academic committee for the human subjects and replacing it with an institutional review board or privacy board. So you'll hear from Lauren, but there are requests for changes with regard to other reports, changing when they're due, whether they're repealed, and also language about recovery service organizations. So that's it.
Okay, so yeah, we looked at this one before. So Lauren, why don't you share with us the information that you have? And I don't think we don't have it online, but we can get it, I hope.
Yes. Yes, we have a statement. Thank you. Lauren Lehman, General Counsel for the Department of Health. So the first edit there would reduce the health equity report to the legislature to once every 3 years instead of annual. We compile health equity reports every year, and then there's an obligation to take all of the health equity report data and pull it into another report to summarize it. And that's the summary report is what we're asking to do every 3 years, just to minimize and make it more efficient. And the data would still all be available, still all be in reports. It just wouldn't be compiled into the data from the other reports wouldn't be compiled into one report until once every 3 years. So that's the request there. The request regarding the registries is technical and why I'm here, but I want to start by saying it is not changing the substantive law. It is to change. So already we have authority, and the legislature has decided that that the department can disclose cancer registry and ALS registry data, which includes protected health information, to researchers who have received approval from an institutional review board and called an IRB. IRBs usually are charged under federal law with looking at studies to make sure that that involve human subjects to protect their welfare, their rights, and their safety. In 2017, federal law changed and made it so that public health surveillance no longer constituted research under federal law, which meant that IRBs would not review and approve studies that involved public health surveillance. That meant that people who wanted registry data, researchers who wanted registry data for public health surveillance, which is frequent, right? You're looking at cancer registry data to survey public health threats and risks, maybe for cancer or ALS. They can't get IRB approval anymore because it's not research under federal law. So it puts them in a stuck position where they can't qualify to get this research. This was also an issue on federal law and under HIPAA. So HIPAA updated to say, okay, well, to get the data without authorization, from the individual, you would need either an IRB approval or approval for something called a privacy board. Privacy board does the same thing an IRB does in terms of looking at the process and the plan study, making sure any PHI collected is the minimum necessary, that there are protections against redisclosure, all of the things an IRB does, but it does it for studies that don't qualify for IRB review. So what we're proposing here to allow researchers to continue to get the registry data is to update the statute and allow disclosure of the data with approval of an IRB or a privacy board. So making it consistent with federal law. It wouldn't substantively change anything we're doing at this time. The other minor change is it says written agreement right now in that same section that the commissioner may disclose registry data with the written agreement of the federal government and other states. Unfortunately, that's been interpreted to mean like a signed written agreement, and we're not able to get signatures sometimes. So we've asked to call it a written assurance that they will retain confidentiality. So those are the two minor changes, and then I can defer to Jessica on the reports and the recovery housing requests. Thank you.
Okay. Go ahead, Jessica.
Good morning, committee. Thanks for the time and consideration of this bill. We had, in response to some of the conversations that have been happening throughout the session, we wanted to propose a new report that would provide the Agency of Human Services and the legislature with a complete understanding of the financial health of Vermont's recovery centers. And, they are also, the technical term for them is the recovery service organizations that have been certified under the existing regulations of the Department of Health. So we are asking for this report that would require the Department of Health, in consultation with other departments in AHS and recovery service organizations, to provide a report to the legislature, really detailing all of the financial aspects of the recovery service organizations. So
that sounds really good, actually. Excellent. Yeah. So
we submitted that language for.
So Jessica, we don't have any language in front of us from you. So what we need is to have it sent. You could send it to me and just say copy Katie, or send it to the committee as a whole and to copy Katie, or send it to Katie. Do you have it?
I have it. I'll forward Jessica's email to you.
All right. Okay, good. She's got it. So that's where it needs to
I'll
be.
send it to Callista.
Yeah, send it to Callista. But continue on, because it sounds like it's some information we could use. And you've got 1 minute.
I'll stop there and wait till you all see the language. In another conversation.
Keep going.
Okay. In another conversation we've been having since the beginning of the session is about broader report requirements. And I think this year the Department of Health had 17 different reports that we submitted to the legislature. And so you had asked about which ones we think we might be able to discontinue. So we also provided a list of all of the ones that we have identified for the committee's consideration. If you would like to make any changes to those report requirements in this bill, we would welcome that in the discussion. So,
all right, we will definitely look at that, because that's a concern for us too. Having too many reports is not helpful. Having really good information in a single report is much better. Okay, so that's the amendment that Katie has.
Yeah, well, I have a chart, and now you're on the email, but now Callista has the documents.
Okay, good.
But there's a chart with a series of reports, and the requests, I believe, are to remove them Is it to remove all of them or is it some of them make them every other year?
Yeah, some of them are to remove them completely. Some of them are to make them less frequent. So,
Okay. All right, I think that we'll be able to handle that. So thank you both for being available. What we'll do is we'll look at that, information before Tuesday. And then we'll make a decision on Tuesday how to deal with all of it. I think the recommendations that we've heard from Lauren are fine. The report on recovery residents and centers sounds terrific. And then we'll look at the reports and see if there are any that you don't want, that we do want, and try and sort that out together. But it won't take us long to do this. That's good. We can come back to this, early in the week.
Thank you.
All
appreciate
right.
it. Thanks.
Thank you. Okay, so we are wrapped.